me. This is Kathryn Fisher from McMaster University School of Nursing, and I'm on faculty there. And with respect to what we're talking about today, I was a member of the research team as well as the statistician on the project. Melissa, over to you.
Thanks, Kathy. Hi, everyone. Melissa Northwood. I'm an assistant professor in the School of Nursing, also at McMaster University. And it was my pleasure when I joined the school 3 years ago to begin working on the scalability assessment with the team. Over to you, Ron.
Okay, greetings everyone. I'm Ron Beleno here in Toronto, and I am here as the patient partner, the lived experience advisor on the team. I have had a parent with diabetes. I have a mom still with diabetes and a lot of family members. So I'm here wearing more the caregiver hat. So I do a lot of work with the team at McMaster and the crew there, and I'll let the team mention what ACHRU stands for. And yeah, looking forward to this conversation today.
Thanks, Ron, and thanks, Kathryn and Melissa. First of all, I'm just going to begin with a land acknowledgement, and then we'll get right into the session and the presentation because we only have about an hour today. So I encourage all of you to think about your particular land acknowledgements in your respective jurisdictions and lands. I myself, I am calling in from Montreal. I would like to begin by acknowledging that the lands that I live and work on are unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and waters on which I call in today. Tiohtià:ke, or Montreal, is historically known as a gathering place for many First Nations. Today, it is a home to a diverse population of Indigenous and other peoples. We respect the continued connections with the past, present, and future in our ongoing relationships with Indigenous and other peoples within the Montreal community. So I'm just going to introduce Kathryn, who is going to begin the presentation today. Over to you.
Thank you. Okay, and Melissa's going to control the slides here, I think. So, and Ron said I had to introduce ACHRU. So that's the first thing I'll do before I go on. So ACHRU is an acronym for our research unit, which is the Aging, Community, and Health Research Unit. And today's talk is about an intervention called the CPP, another acronym, Community Partnership Program. And this is an intervention for older adults with diabetes and multiple chronic conditions. So we're going to focus on, in particular, our assessment of the scalability of that intervention. And the objectives of today's session, we hope to share with you the following information about the CPP. So what is that intervention? A little bit about that and the program of research around it. The purpose of a scalability assessment. So then we're going to focus the rest of the talk on how we assess the scalability of the intervention. So why we do it, the tool that we use to actually assess the scalability, patient partner involvement in that activity, the scalability assessment, and then the challenges in assessing scalability of an intervention, and this one in particular, which was run during COVID. And just to acknowledge that Melissa and I are representing a rather large team here of folks from researchers from 4 provinces, so Ontario, Alberta, Quebec, PEI, and also patient partners are on this slide as well. We've got a patient partner from Alberta and another one from Ontario that were investigators on the team, and lots of co-investigators. So there's a big team here, as well as a community advisory board that guided the work of this research team. So we had community advisory boards in Ontario, Quebec, and PEI that helped our research team. And then also, even the net goes broader here because we have partnered and collaborated with a large number of other groups. So here we see our study site, St. Michael's Hospital and Scarborough Health Network. So we collaborated with study sites. We collaborated with various organizations, Diabetes Action Canada, Beacon, community organizations like the YMCA, Care First Seniors and Community Services Association, and provincial and regional health authorities. So Ontario Ministry of Health and Long-Term Care, the LHINs in Toronto, Central and Central East, for example. So lots of organizations, community organizations, study sites, provincial governments involved as well. And next slide. And then funded by a number of folks. So CIHR, both the programmatic grant, the PICI programmatic grant, and the research chair for the nominated principal investigator, which was Dr. Marco Reed from McMaster University, and then other sources. So Scarborough Health Network, the Baxter Foundation, Diabetes Action Canada, McMaster Institute for Research on Aging, and Quebec organizations here. So lots of funding sources that generously contributed and enabled this work to happen. So the ACHRU, Aging Community and Health Research Unit, CPP, the intervention. So we're going to start with why did we focus on older adults with diabetes and multimorbidity? So diabetes is highly prevalent in older adults, 22% for those over 65 years of age. And so the highest prevalence of diabetes is actually in this age group. But then in addition to diabetes, many of them have other comorbid conditions. So 40% of this target population, older adults with diabetes type 2, have 3 or more comorbidities and other conditions, other chronic conditions, in addition to diabetes, which has implications for lots of research has shown that higher comorbidity is associated with higher mortality, physical functioning, poor physical and mental functioning, challenges in self-managing diabetes and those other conditions, as well as higher health service use. So lots of challenges with this target population. And the care delivery models are equally challenged. So care for these folks tends to be incomplete or fragmented, not coordinated across care settings. Best practice guidelines are actually typically organized around single conditions, so don't recognize multimorbidity and that suite of conditions that patients are trying to manage. And then a limited attention to social determinants of health and other non-health related conditions that actually have an implication for health. So lots of challenges with the existing delivery models, which leads us to the ACHRU CPP, which was intended to address some of those gaps in the care model. So the CPP is the intervention that we analyzed here and evaluated, and it's a 6-month program delivered by interprofessional primary care providers who were a registered nurse, registered dietitian or nutritionist, and a community program coordinator, which was typically a kinesiologist from a partnered community partner organization like the Y. And so that was delivered by that team. And on the left-hand side are the 4 key components of the intervention. So the first one was home visits. And I should say, these components didn't come out of thin air. We actually did quite a bit of work to develop these. So we had focus groups. This is going back 7 or 8 years with providers and patients to inform what should this intervention consist of. Best practice guidelines, looking at the literature. We looked at all of that, and that's what we used to actually come up with these components that we delivered in the CPP. So the first component was home visits. So up to 3 in-person or virtual visits were offered to clients in the intervention, and they were delivered by the RN and or registered dietitian or nutritionist. Then the second component was group sessions. So we offered up to 6 group sessions, and these are wellness sessions that were either in person or virtual, depending on when the intervention was delivered. And these provided health education, information on physical activity, and peer support. The third component was team-based care, and what we mean by that is the interventionist team, met monthly for the 6 months of the intervention to discuss the care plans for the clients and to make sure that the team was on the same page with respect to that care plan. And then finally, care coordination and system navigation, that was the 4th component. And so that was the care coordinator on the team was responsible for tailoring that coordination and system navigation to resources relevant to each of the clients, and also to communicate with their primary care team. Those core components were intended to impact the outcomes on the right-hand side, the intended outcomes. So we were looking to improve mental and physical functioning, diabetes self-management, physical activity, and reduce some of the negative outcomes. So reduce nutrition risk, mental health through depressive symptoms or anxiety, and then the cost of the use of health and social services. And that program of research, the CPP or the CPP intervention, is located within this program of research, which actually consisted of 3 studies. So to read this, it's a bit of a busy slide, but on the left-hand side, those blue ovals are what informed this program of research. So the work that went on before we even started this program of research, we had those focus groups that developed the intervention. We ran a pilot and feasibility study to make sure we could deliver the intervention and recruit folks to the studies. And we also ran a pragmatic trial in both Ontario and Alberta initially to test the intervention. And that was all promising, which led to this work. And this program of research was 3 studies. And what we started with in study 1 was a population-based study. So we looked at administrative data, and we were looking to see what the characteristics of a more vulnerable group in the target population, what they looked like. So we had noticed in our previous trials and previous work that we didn't have a lot of folks that were high system users. And high system use was, in this case, defined as high emergency department use. So we didn't have a lot of that vulnerable population, and we wanted to get more of them. So study 1 was intended to at least help us understand the characteristics of that group, and that informed the recruitment process for the trial. So we were hoping once we understood them better to be able to recruit with those characteristics in mind. So study 2 was actually the trial, the pragmatic randomized controlled trial that we ran, and it was really looking at both implementation and effectiveness. So it was looking at both. Does it work, and how do we deliver the intervention? So that was study 2, the clinical trial, and that then informed the right-hand side, which is assessing scalability. And then we actually show it along the top, that arrow that goes really across all parts of this program, as we were synthesizing that information, past work, the current RCT, and then we ran provincial forums where we involved other folks from the policy practice setting in the provinces that we were running the trial in, so that we could fully assess and synthesize all of this information, which ultimately led to that right-hand side, a provincial scalability assessment, which we did for 2 provinces. So the RCT was run in 3, Ontario, PEI, and Quebec, but we could only assess scalability in 2 of the provinces, Ontario and PEI, because Quebec had to pull out and end the trial early due to COVID. So Ontario and PEI continued all the way through, and we could therefore assess, and we had enough information to assess scalability of those 2 provinces. And a little bit about scalability now. So we're focusing now on that study 3 component of the program of research. And just in case scalability, that term is new to folks, it's the ability of a health intervention shown to work on a small scale or under controlled conditions to be expanded to a broader group. So the idea is, does this intervention, can it be rolled out to more people and stay effective? So something that's been shown to be effective, which was the case for us, we had done in our previous work, had clinical trials showing that the CPP was effective. So, and then the current clinical trial had its own set of results, but the idea is, can we actually roll this out to even a more broader population and stay effective? And for us, this process involved 5 components. So the first one was, where we started with the scalability assessment, is we formed provincial working groups. So these were patient partners, researchers, primary care service providers, policy and decision makers that were all members of these provincial groups for Ontario and PEI. And they provided input on the scalability of the CPP from their own setting. We also did a document analysis and environmental scan. So we were there looking for other policy documents to help us understand initiatives and priorities in the provinces, other resources that were relevant to this population on a community or provincial basis. So we pulled those documents as well, so we could better understand resources and direction from the provinces. And then we also interviewed key informants. So these were folks that were from health ministries and healthcare leadership positions that might be involved in scale up. and we interviewed them to get their perspectives. And then finally, or the fourth component, not finally, a fourth component was we held scalability assessment workshops virtually in December 2022 in both provinces, Ontario and PEI. And there, the folks in attendance actually rated the CPP using the tool I'm about to show you, which there's a number of components to consider, and everyone rated the intervention on those components. And then finally, the last step was we shared the scalability report. So we synthesized all of that information from the workshops and the rest of the evidence and wrote it up in a report to share with participants, policy, and decision makers. Now, the tool that we used for the scalability assessment it's called the ISAT, Intervention Scalability Assessment Tool. And there's lots of intervention scalability assessment tools out there. We chose this one because it had been designed for a developed country, and lots of the other ones were more for developing country interventions. So that was one of the reasons for choosing the ISAT. It's also been used quite a bit by others. So there's some consistent literature out there in the use of the tool and guidance on it. The idea of the tool is to conduct us, or to enable us to conduct a systematic assessment of the suitability of the intervention for scale up. And it consists of two components, a part A and a part B, and then 10 domains, so 5 in each. So part A is about looking at the healthcare problem and the intervention and its effectiveness. So the problem is what is the problem among older adults with diabetes and multimorbidity? The intervention is what is it and how does it address that problem? Political context is the fit of the intervention within broader initiatives and directions and changes that are happening in the practice setting and in the province, healthcare wise. The effectiveness of the intervention, and that's both with the current trial and any previous evidence we have in literature that's on similar interventions. Has it been effective in addressing the problem? And then looking at costs and benefits of the intervention and its delivery. And then part B is about the implementation, or more focused on implementing that intervention. So fidelity and adaptation, fidelity meaning were providers able to deliver the intervention as we had intended it to be delivered? How did they have to adapt it to local settings? Reach and acceptability, was it acceptable to providers to deliver it, patients to receive it? What was the engagement level of clients in the intervention and in the different components? Delivery setting, workforce, implementation, infrastructure. So that's looking at who delivers it, where, what is needed to actually deliver that intervention. And then finally, sustainability is about maintaining it over time, being able to deliver the interventions. And now I'm going to turn it over to Melissa to talk about the results that we got from the workshops.
Thank you, Kathy. So we thought we would share the results in each of the provinces where we did the scalability assessment. So here we have a radar plot of the results of the assessment in Ontario. So in the rating, each participant rated the domain based on the degree of readiness from 0 to 3. And the higher the score, the higher the degree of readiness. So you can see from this plot here that the participants overall highly rated the scalability of the community partnership program, between 2 and 3 on average for each of the domains. And this was true in both of the provinces too. So if we look at the different domains for A1, they identified diabetes among older adults who are also living with multiple chronic conditions as a significant problem that would warrant the scale up of the program. They agreed that the key components of the intervention were reasonable and that they met the needs of older adults. So that's looking at A2. But they, in Ontario, they also suggested that the intervention could be adapted more to the local context, considering different ethnocultural communities in the study sites of Toronto and Scarborough. Then for domain 4, they rated evidence of effectiveness as relatively the lowest. As in this trial, as Kathy mentioned, that was conducted in the pandemic, we found no statistically significant differences between groups in the trial. But there was consistent positive qualitative findings from both the older adults themselves and the providers delivering the program. So participants acknowledged that while they rated this domain lower, there was a significant impact on the program because of the pandemic. The program was designed to be in-person delivery and had to change to become virtual and remote partway through the trial. They also thought, in terms of the evidence of effectiveness, that maybe we needed different program outcome measures that might be needed to detect additional benefits. So maybe we weren't measuring the right outcomes. Moving along, looking at the fidelity and adaptation there, reach and acceptability, domain B2, they recommended refining the program inclusion criteria. It was older adults with diabetes and multiple chronic conditions, but they wanted to tailor this to be older adults who would benefit the most from the program. So in Ontario, they thought that this might be racialized older adults, and they really thought that we needed to do some different marketing in terms of pitching the program to potential people who would benefit by really defining what was in it for them, for the older adults and the caregivers. What could they expect in participating in a program like this? Looking at B3, the delivery setting and the workforce, participants were concerned that the designated funding for this type of program might be difficult to obtain in Ontario in the quote unquote post-pandemic recovery and all of the competing demands in the system. So then I'll give you a snapshot now of PEI. So here's their radar plot. And again, the participants did rate the scalability on average quite high, between 2 and 3 in each domain. Participants in PEI also agreed that the problem, diabetes in older adults, was a significant problem in PEI that warranted scale up. They also agreed with the key components of the intervention, that they were reasonable and I would meet the needs of older adults. And they, from the kind of strategic political context, domain A3, they thought the program had really good alignment with and potential for integration with some of their new primary care initiatives, including the patient medical homes and the patient medical neighborhoods. And they also noted that the use of a new provincial electronic health record could really help to support the introduction and integration and then ongoing program evaluation of this program in PEI. For A4, they rated the evidence of effectiveness relatively lower, like the participants in Ontario, because of the no differences in the trial. But they agreed that there was many challenges because of the pandemic. And they too were interested in using different outcome measures. They thought maybe a more global measure of self-management might be a better way to capture change with the program. They also thought, in terms of reach and acceptability over to B2, that refining the inclusion criteria, again, to think about who the program might benefit the most. And in PEI, they thought this might be older adults who are high users of the healthcare system. In terms of delivery setting and workforce, they agreed the program could be integrated into primary care, but their main concern was there's significant nursing staffing shortages in the province, including certified diabetes educators. So that would be a real workforce challenge. In terms of the implementation infrastructure in B4, they thought that this was going to fit and that it would be really important when we were communicating with decision makers to emphasize the importance of the program for older adults, because there's a lot of competing priorities right now with the primary care redevelopment in PEI. And in terms of sustainability, they brought up that provincial electronic health record. How awesome is that? And they said that that would certainly facilitate sustainability of the program and figuring out what works and for whom. So just to summarize our key learnings in this scalability assessment step, the context really matters. And it was so important to assess the readiness to scale up in the local context. We had thought we might be able to do it nationally, but it was a good decision to do it provincially, and even drilling down even further in the different sites in the provinces. Getting different perspectives was essential for this process, and it really helped us think about threats and enablers in moving research into practice. While we had a lot of consensus, the policymakers, health and community care leaders, and the patient partners all brought very different ideas to the table, which was very helpful. And tensions do arise in this type of process, and we had to balance the different types of evidence to inform next steps. For example, there was a lot of enthusiasm from the participants for identifying a target population of older adults, and this was based on their knowledge of their local community needs. And then from the research side, we were worried because we don't have that evidence base yet on who would benefit most from the program. So our next steps are hopefully with our partners to work on that and figure out what group of older adults would benefit the most from the program. And this would help add to the evidence and impact as well. So we'd like to start with the scale up of the CPP with priority populations in a more phased horizontal approach. So that would be starting with some of our partners they're ready to go, rather than kind of a national implementation. We'll start small and learn as we go, really leveraging the existing infrastructure where people know their communities and are interested in redesigning their care delivery systems to accommodate this program. And then we'll continue to gather more information on the effectiveness and implementation from these more targeted scale-up efforts. So having shared a bit about the scalability assessment, I'd like to turn it over to Ron now. And Ron, we were hoping you'd be able to tell us a bit about you, a bit about your role in this project, and why it's important for patients or citizens to become involved in research as partners.
Thanks, Melissa. So hi again, everyone. So earlier when I introduced myself, I mentioned that I was from Toronto, but more specifically, I'm from Scarborough. And that is where one of the projects, where some of the work was happening. And how I was introduced to this was actually through another meeting that I was at regarding patient engagement and primary care. So just for everyone to know, I'm actually kind of not new to this space when I was introduced to this team. Okay, I was already quite involved in patient engagement. I was already doing work with an organization called ACHRU, which is Canada's Technology and Aging Network. So I already understood patient engagement. And just so we're also clear, sometimes people get confused between patient engagement, co-designing with patients on your team versus patient participation. So I just want to make sure that we're clear with all that as well, that sometimes people overlap that. So I'm not there as a participant. I was there as a knowledge user, as a patient partner. And it was Rebecca Ganan who actually said that they were looking for some people and asked for my support if I could help find. But I said, hey, by the way, I deal with diabetes, in my world all the time. And when she said, well, yeah, we're trying to do some work in Scarborough, I said, well, I don't know if you know, but I actually live in Scarborough, and I actually used to run a community center in Scarborough. So there's a personal connection for me that this was easy for me to say yes. Just again, very quickly, for those that don't know about Scarborough, some famous people, I just had to make sure I had my list here. We have Mike Myers, okay, we have Lily Singh, an actress there. We have the singer The Weeknd, who is from Scarborough, and also a voice actor, Eric Bauza, who is the voice of Bugs Bunny. And why I know Eric is because actually Eric's my cousin. So things like this, it's, as you can tell, it's a very diverse community. And it's quite important when, let's say, you have researchers who happen to be coming from another community, Hamilton, McMaster. The odds of you understanding Scarborough would be rare, if you haven't lived there. So for me, the importance of getting not just the community organizations there, but also the patient partners, for myself, the caregiver partner, as a knowledge user is quite important. I understand the diversity. I understand the pockets as well in Scarborough. Okay, and also for me, it just happens to be that I do a lot of work in healthcare as well. So that is what I brought to the table. And then it was just one of those where if you do get, some patient partners that are willing to speak, willing to not just nod their head, okay, our job as well is to actually constructively criticize, constructively agree on some of these, on some of the work that's happening. And we don't want to kind of hear it from the researchers at the very end and say, oh, by the way, you should do it this way when a lot of the work's already done. So it's co-designing at the very beginning and throughout the end. One thing, Melissa, I do want to mention as well is that being on the community advisory board for Scarborough, which was created, I was one of the co-chairs. So as a patient partner co-chair, and we would have, over the years, we had to switch up. We had one initial co-chair with me, but then she moved on in her role with her organization, and then we had another one afterwards. So that worked out quite well, in my opinion. And again, it was our role as patient partners to not just myself, by the way, there was another two others, I believe, that were also in the community advisory board helping out along the way, who understood the community. So they weren't new as well to research and diabetes. So yeah, so that's a gist. Yeah.
Thanks, Ron. I don't know, Jamie, if this is okay, but I thought this is perfect timing to go to the one question that's in the chat, since we've got Ron is speaking to this exact topic right now. We had a question from Ali Ben Sharif that agreeing that scalability assessment is critical to ensure effectiveness, efficiency, equity will be maintained at a larger scale. And he's asking about what about patient-centeredness? And how were patient partners involved in the scalability assessment? I think you've answered the second part of this question, that you were not participants, you were partners, but maybe if you could tell us a bit more about that that particular phase, Ron.
Sounds good. So I'll leave the scaling up. Sorry, the that participant, if you guys want to answer that later. But greetings, Ali. I actually know Ali. I didn't realize he was here. So Ali, actually, I worked with Ali at University of Laval with France Legare, who is a Canada Tier 1 chair in shared decision making. So it's so refreshing to have you there, Ali. I hope you're keeping well. So the first question, person-centered. So a lot of the work that I've got to see over the years in the research community and in healthcare across Canada has been shifting a lot to patients or person-centered focus. And for this, I'm even going to kind of rephrase it. I'm not the best when it comes to the academic language of how you all speak, but I'm even going to say it's community-centered. Okay, like Scarborough's not the same as Hamilton. It's not the same as Prince Edward Island. Even the pockets, as I said, in Scarborough. Melissa, you mentioned, I think, around the scaling up, the local context piece, how important that is to scaling up. That's in the scaling up piece. That's also in just doing the research, is that person-centered research to understand, Ron can talk about the Filipino community. There's a South Asian community in Scarborough. Scarborough is extremely diverse. Okay, there's the socioeconomic challenges that some face, let's say. So I felt that was there in the work that we did. I really felt that the team consciously and the research team, kept trying to figure that out along the way, that we were all trying to understand that, which is a challenge. Okay, it's kind of like person-centered work. Sometimes you can't please everybody. There's in my opinion, you can't always cover everybody. But so I'm not really answering it. I'm just going to say from the research side, it is a focus that this team brought and continues to bring along the way. It's just a question of how person-centered can we be to even the most unreachable, let's say, individual out there. It's kind of hard to try and focus on every single person versus trying to get that group and just getting to that audience, if that makes sense. But anyways, that's my response there.
Thanks, Ron. Yeah, I think that was perfect. Thanks for sharing how you were involved. when we're thinking about the scalability assessment, I know it was back in December, but I remember you being very conscious of bringing in the caregiver perspective, because this program was designed for both older adults and their caregivers, and not as many were involved as we had hoped. Could you tell us a bit about how you brought in that perspective as well into the scalability assessment?
Yeah. So for me, because I am a caregiver, I do a lot of work around caregiving nationally and internationally. The voice of the caregiver needs to be addressed, especially when we're doing some work with aging adults. Not all aging adults need a caregiver or require a caregiver, but you'll likely see a caregiver there, okay, in the picture. Or, am I still here, Melissa?
Yes,
Nope.
you're here, Ron.
You're there,
Oh,
Ron.
sorry. Oh, I saw Melissa frozen. So one of us is frozen. I'm not sure who's frozen, but okay, sorry. For me, it comes back to that, as from my work in the aging space, that we do need, I think we did lose Melissa. Is that correct? Sorry. Anyways, I'm talking to everybody else here. So it is just one where the caregiver piece is kind of, I think, a vital role in the healthcare system. And specifically for the aging population, whether that's informal caregivers, informal being those that are not paid, usually family members or friends, is that they play a piece in the influence of how aging adults, might take care of their health. So my mom, for example, or my aunts and uncles, it just takes me to kind of make a few comments, plant some seeds and say, hey, you know what? The Filipino diet is probably not the best diet if you're taking care of diabetes. So pay attention to that. Okay. And that's not new. South Asian diet, Southeast Asian diets, a lot of sugars, sweets, we like our desserts. But sometimes it's that caregiver that plants the seeds, and then it's amongst them when they go to their Filipino groups, when they're hanging out together, and they say, did you know that this and this is not really good for our diabetes, that this could lower our sugar, whatever that is. So it is just something where the caregiver plays a huge role, that supporting the caregiver actually supports the healthcare teams out there, the research teams, to move the work forward. So leverage that, and learn how to leverage, okay, the caregivers that are on your side. They just need that support to either get educated or some tools and strategies to help scale something up. They don't know how to do it, right? And so something like the work that we're doing here, it's been done. It's just now, how do we scale it up? Well, how do we now get it in front of them? And that's where the help of, again, a knowledge user, a patient partner who understands that community, can help. I can't go into Prince Edward Island, in my opinion, and just start telling people this is how we should do it. Okay, I don't know the culture. I don't know the fine nuances that's there. So, yeah. So that's some of my comments on that. So Jamie, I'm not sure if Melissa's back, but
She isn't, but I think
Yeah.
we'll just, thanks so much for that, Ron, and thanks to Kathryn for the great presentation. And I've learned a lot about this program, and certainly scalability assessments as well. So this is wonderful. Thank you so much. For those of you online, please feel free to put in your questions in the Q&A chat portion of the webinar. I didn't mention that earlier. And we'll try to get through some of these in the latter portion of this session. We have about 20 minutes. So the first one was sort of touched upon. I think one of the questions, though, was how were patients involved in the scalability assessment? Just wanted to kind of get a maybe more nuanced answer to this. Because I know, Ron, you were a patient partner in this project, but you weren't, as you mentioned, you were not a participant. So Ali wanted to really kind of understand if there were participants, patients as participants in the scalability assessment study. And Kathryn, did you want to begin with answering this?
Yeah, we we did not have participants from the study on, as far as I know, Melissa, we did not have participants in the study on in our provincial forums, but we had patients that represented, that were representative of that group on the provincial forums. And I think also the providers had this lens, this patient-centeredness lens, because when linking back to what Melissa said, is they were saying as a recommendation for next steps to actually select priority populations, to actually select those that were marginalized and focus and tailor the intervention even further. So that's where the patient-centeredness was actually coming out, as certainly the providers were recognizing that they were getting unique needs, unique requests, unique priorities from these patients, and the intervention could be better tailored to actually help address those than it was. So that, I think that links to that recommendation itself, is that providers recognized we even have to do more on patient-centeredness to actually deliver and address the needs of diverse populations.
Yes, Kathryn, if I can add to that. Yeah, so I do recall, I don't recall patient participants, at that stage, but actually a key point you said is also the voice of the providers, okay, the local providers that actually knew their patients well. So they actually were there also advocating for those patient groups. Okay, so they would take their provider hat, healthcare hat off as well, but saying, okay, I know this group that has been pushing for this, or like that this is who. So they also technically are advocates for the, the patient partners. And people forget about patient-centered care isn't always just from the voice of the patient. It's always some of the champions, are actually the healthcare providers that really are intimate with their community. So that is just kind of something that needs to be understood. It's not always the patient voice, it's who's there that can represent the patient voice as well. And we forget sometimes it's also some of the individual staff members that's intimately with them. So
well, I'm thinking of Ethel's comments from Scarborough about just recognizing these diverse people that you're trying to deliver the intervention to. And so she was saying, we still have a ways to go here, but they've identified new pathways that they can actually use to target better some of these diverse populations. We can still go further, but she was recognizing that the intervention was actually opening a door to a more tailored approach to even the people they're serving now. So yeah.
Correct.
Great, thanks to both of you for that. And Ali and Sharif also included an 11-item measure of user and human-centered design for personal health tools. So it's a tool that might be able to, you can maybe consider in future as part of your next steps, or some tool that can maybe help assess in this area for you. So I encourage you to check that out.
That's great. Thanks, Ali Ben.
And any other, Melissa, did you want to add anything at all to this point?
Oh, sorry. It's like your worst nightmare ever. The screen freezes. I'm like, oh no, I'm booted out. So my apologies, everyone. I lost my my internet. And I missed some great discussion. I'm sorry. The one thing I wanted to add, and Kathy, stop me right away if you've said this, is when we picked this particular tool, we recognized it was a limitation, that it didn't include a citizen or a person voice. So we, even though we used the tool that wasn't designed to be used with citizen or patient partners, we made sure that they were included as part of the scalability assessment to overcome that deficit in the tool.
Okay, perfect. That's great, and that you're able to adjust, which is always good. Yes, and I also liked Ron's comment about including other partners. Some in addition to patient partners. Even, and I think you mentioned this, that you included policymakers as well. So it's kind of like researchers. All four partners have different perspectives and really can so including them in the project early and throughout is probably really important. Really, some of the work that we do as a network, and the Canadian Primary Care Research Network, is always kind of goes back to those engagements with those key partners. So I thought we have about a little less than 15 minutes. I'll go to the second question here. Is it possible to speak to the frameworks, theories, survey tools that were used at different points in this project to assess for contextual readiness, perceived and or actual barriers and enablers experienced with the implementation of this program? Who wants to begin with this? Melissa, do you want to take a crack maybe at this first?
Could you repeat the middle of the question?
Yeah,
I'm sorry.
so is it possible to speak to the frameworks, theories, survey tools that were used at different points in this project to assess for contextual readiness, one, perceived and or actual barriers and enablers experienced with the implementation of this interesting program?
I'm thinking CPHR, Melissa, might be something to mention there.
Oh, do you want to start with that, Kathy?
Well, does matter. Yeah, I think when I hear the question, I'm thinking of implementation tools in particular, and we used CPHR, which is the Consolidated Framework for our Implementation Research, I believe, and it's by Dan Schroeder and their group. So it does look at barriers and facilitators of implementation. So we use that actually as the framework for analyzing data that we captured during focus groups with providers in each of the study settings. And then I would say that not implementation wise, but there were, and I don't think we ever mentioned all of the different outcomes, and there were a whole host of them here. We had 9 different survey tools embedded into a gigantic data collection tool. So we used SF12 for mental and physical functioning to measure that at the beginning and 6 months later after the intervention. We had the ORs for limitations on activities of daily living and independent activities of living. So we had that. We had a physical activity measure, which was, oh my goodness, I can't remember the tool name, but anyway, there was a tool for each one of these things, and we actually went after costs of delivering or receiving services, health and social services, and we captured costs. So there wasn't really a tool as much as just going through, you know, acute care and community services and making sure we captured all those costs. And we used CESD for depressive symptoms to measure that. So a whole host of tools to get those quantitative outcomes in addition to the CPHR outcomes for implementation. I don't know if that's answering the question, or Melissa, if you want to add to that.
Yeah, thank you, Kathy. And as Kathy mentioned, the qualitative component of the project, we asked providers and leaders and community providers as well, like social care providers, to reflect on the scalability of the intervention. So we looked at that qualitative data as well when we were doing the scalability assessment. So that's kind of getting into some of that contextual readiness. And we looked, when we were doing our environmental scan, we were looking at, we kind of started nationally, like what are the national strategies for diabetes, then we went more provincially, and the further we got along, and it seems kind of silly saying this out loud now when I realize how important it is, but the further we got along, the more we realized that we really had to look much more at the local community context. I know I've said that before, but that was what was going to make the difference. So initially we thought, well, let's look and see how many YMCAs there are across Canada. I'll let Ron, I know he's got to go to another commitment. Did you want to have a last word, Ron?
Oh, sorry to interrupt. No, sorry, everyone. I do have to step out because I actually am going to another patient meeting. So this is actually with ACHRU. So I'm on the board with the Ontario Sport Support Unit, and we have our board meeting to support work like this, okay, to make sure, and I think I'm preaching to the choir here. I don't know everybody on the call, but I will assume, okay, and of course, when you assume, you make an ass out of you and me, but I'm going to assume that many of you are already on board with patient engagement on your team. So I'm just going to put that out as a reminder to keep moving that work forward, please. You know, the citizens as your partners, as you co-design along the way, not just at the very end. So that's just kind of my last comment. Just like how this team does it. They do an amazing work making sure we're part of it there. So thank you everyone on that.
Thanks for being with us, Ron.
Okay,
Thanks
thanks,
very
Jamie.
much.
Take care,
Thanks,
everyone.
Lily, Ron.
Yeah.
Thanks.
Bye.
So sorry, just to conclude that, so we had like this inventory, for example, of YMCAs across Canada, and we thought, well, we really need to talk to the YMCA that might partner with us, like that hyperlocal intel and knowledge. So that we quickly, instead of casting a wide net, we started to get narrow and narrow and narrow in terms of understanding the needs of the community. And then that informed our working group, helped us decide what key informants might be able to give us more of that perspective as well.
Thanks, Melissa. And I think to build on that, my question actually that I came up with while listening to this great presentation was the finding regarding how certain partners believed that some of the outcome measures were not the right things to measure. I thought that was really interesting. That stuck out to me. So I was just curious, how did that interesting finding develop some of your next steps, and how what is your approach to trying to find the correct outcome measures to collect this data? Because even as a network, I think we struggle sometimes to collect the right data that measures our true success. And I'm just curious, that finding was interesting to me. I'm just curious from your perspective, what your next steps are in that regard.
Maybe I'll start, Kathy, and then if you want to jump in, but I think that's the $1 million question, Jamie. And I think we most importantly is we'll have to work on that with our partners and the sites that are willing to move forward with this intervention, and also look at what they're already collecting, because this was, although it was a pragmatic trial, we were adding in these tools that are often used in research and are not always part of routine clinical practice. So we'd be looking at something they're already using. For example, in PEI, they use the diabetes distress inventory. It'll soon be in their electronic health record. Can you imagine? So they're going to be able to collect it once and use it in multiple ways. Use it at the point of care with the person, and then use it to understand the impact of the program. So I think we'll have to maybe look at what we used and look at what's being used, and then find that efficient, impactful middle ground.
Thanks, Melissa. Anything to add to that, Kathy?
Yeah, I would. I agree, and what a lot of what Melissa said is quant focused, and here's the statistician hat, and I'm going, yuck. Like sometimes the quant does not capture the construct well. So and you have to balance in a study how many things you can possibly collect. So that was part of it. We had 9 outcomes, and that means 20 some odd questions, and that was huge. But some of the things that we didn't capture: care experience, team collaboration, some of these, what all the providers were saying were really, really important constructs, are not easily measured quantitatively. And why do we have to, like, I'm thinking of Ethel now from Scarborough, who's not on the line here, but she would say, I just know this makes sense. I just know we should be doing this, and it has to improve outcomes. Maybe the time frame, that we looked isn't long enough or something, but it's just, it resonates with what makes sense from a care, providing care standpoint. So sometimes it's backing off trying to measure things quantitatively, and at least capturing these other elements that are important to care delivery that don't quantify, but are really, really important. And the providers were saying that in this study quite a bit. So they, yeah, you didn't see anything on those quantitative measures, but I just feel this was the right thing to do, and they're going forward doing those things anyway. So it's elevating almost that qualitative piece, and recognizing it's, without trying to quantify and put a number on things, recognizing its importance in care delivery and moving forward with the intervention.
Great, thanks for that. So Lee has provided another tool in there. The ACHRU 4.0 is now a patient-oriented scalability assessment tool, including 12 scalability components. So that's another resource he encourages you to check out. he said this is why he was asking that question originally was, for example, as we are also scaling harms only, end users can confirm the level of harms they can be accepted. So that there are real. So he does provide a couple of examples. I'm not sure if there's any other follow-up questions with anyone online. Please, I encourage you to do so. You have about 3 minutes. Maybe we can take one more question.
And I would add to that scaling benefits and be, because that's what we ran into when we were actually in the forums was we're scaling benefits now. How do we capture those benefits so that we can see that side of it? It was mostly costs on, that we were capturing in terms if there were any,
right,
but not the benefits and quantifying or capturing that somehow.
And maybe that's one of the only ways you could do it is qualitatively for that piece.
Cost benefit studies are awkward and have their own challenges. So we were reluctant to go that far in that kind of analysis, but we can't ignore the benefits that people are saying are there.
Just as a follow-up question, in terms of next steps, I don't know if, are you just going to continue to look for funding partners as well to push this work forward to other places? And what are some of your next steps in that regard, just to kind of keep this great work going?
It's interesting that you ask, because next week we have a meeting after this to talk about planning for our final steering committee meeting. So we're going to look again to our partners to see what way should we go. What's the best next step to try to do kind of a wraparound embedded research approach, maybe with some more local funding? Will we go for a grant and move on and gather more evidence? So we'll stay tuned. Kathy, what do you? we're gonna.
No, I mean that's exactly where we're at. Is we're asking ourselves that question and looking at funding. We have some of the existing study sites who have suggested going forward in very locally. So it becomes how do we make that happen? Is it local funding so that they can continue? Some are adopting the intervention without that. Others are saying, well, if we were to start, here's where we would start. And then, we're just getting going on those conversations, but we're not sure either.
Let us know if you need a letter of support for sure for any grants you apply for, because this is great work.
Thank you.
Thank you.
I guess we're going to let you go 1 minute early. Thanks so much for this great presentation. And I encourage all of you online to complete the evaluation that we have once you leave the meeting. And that is the last session for this year for the learning series. And we will be in touch to kind of co-develop the next year of learning series sessions. So stay tuned to that. And everyone have a great afternoon. Take care. Thanks so much.
Thank you, Jamie.
Thank you, Jamie. Jamie, can you save